Welcome to Healthcode Blueprint. Today we're covering Section IV of the ICD 10-cm guidelines for outpatient diagnostic coding, and we'll give you a clear, practical understanding of how outpatient coding really works. Quick disclaimer. This video is for educational purposes only. Always follow official ICD 10-cm guidelines in your organization's policies. Let's get started. Before we jump into the outpatient rules, let's talk about why these guidelines exist. ICD 10-cm isn't just about billing, it's about creating a standardized language across healthcare. When everyone codes diagnoses the same way, it improves data quality, supports reimbursement accuracy, and helps providers deliver better care. So everything we're about to cover ties back to that goal: consistency. One of the biggest things coders struggle with is understanding that inpatient and outpatient coding follow different rulebooks. Inpatient coding uses UHDDS rules and focuses on the condition established after study. Outpatient coding is different. It focuses on the reason for the encounter, even if the diagnosis isn't confirmed yet. So as we go through these slides, keep that divide in mind. In inpatient settings, not every condition gets coded. A diagnosis has to actively affect patient care, meaning it triggers evaluation, treatment, diagnostic testing, longer stay, or increased nursing care. If it doesn't impact the current stay, it doesn't pass the UHDDS funnel. But remember, history codes can still be used if they influence current care. Sometimes providers list old or resolved conditions in the final diagnostic statement. But unless those conditions matter for the current stay, we don't code them. If a past condition affects today's care, that's when a history Z code comes into play. In inpatient coding, the principal diagnosis is the condition established after study to be responsible for the admission. Outpatient coding doesn't use that term. Instead, we use the first listed diagnosis, the main reason the patient came in. And remember, in outpatient coding, you always start in the alphabetic index, not the tabular list. This is a big one. In inpatient coding, uncertain diagnoses, like probable, suspected, or likely, are coded as if they exist. But in outpatient coding, that is absolutely not allowed. If the diagnosis isn't confirmed, you code the highest degree of certainty, which usually means symptoms. For abnormal labs, imaging, or pathology, in inpatient settings, you only code them if the provider documents clinical significance or orders further evaluation. In outpatient settings, you only code abnormal findings if the provider confirms them as a diagnosis. If not, they stay off the claim. When a patient comes in for outpatient surgery, the first listed diagnosis is always the reason for the surgery, even if the surgery gets cancelled. If complications happen, the reason for surgery stays first, and the complication becomes secondary. If the patient ends up in observation, the sequencing depends on whether they came from surgery or were admitted directly for a medical condition. Symptom codes are your backup plan when no definitive diagnosis is confirmed. But don't code symptoms that are integral to a confirmed condition. For example, don't code nausea if the provider diagnosed gastroenteritis. Only code additional symptoms if they're not routinely associated with the confirmed condition. For diagnostic-only encounters, the first listed diagnosis is the reason for the test. Chronic conditions can be added as secondary. If the patient has no symptoms and it's just routine testing, use Z01.89. And if the test is interpreted and a diagnosis is confirmed, you code the diagnosis, not the symptoms. For therapeutic services, the first listed diagnosis is the condition being treated. But there's a major exception. For chemotherapy, radiation therapy, and immunotherapy, the Z code for the service is listed first, followed by the diagnosis being treated. For pre-op evaluations, the first listed code is always Z01.81. Then you add the condition requiring surgery. If the pre-op exam uncovers new findings, those get coded too. In ambulatory surgery, if the postoperative diagnosis differs from the pre-op diagnosis, you code the postoperative one. Why? Because post-op findings are considered more definitive. For routine exams with no symptoms or abnormal findings, use Z01.89. If the exam uncovers a new condition or a change in severity, use the Z00.0 or Z012 code for exams with abnormal findings, and then code the abnormal finding as secondary. Z codes cover a huge range of encounters that aren't driven by active disease. This includes routine exams, screenings, aftercare, social determinants of health, personal or family history, and encounters without disease like vaccinations or counseling. Z codes are heavily used in outpatient settings. ICD-10-CM requires coding to the highest level of specificity. That means using all required characters, including seventh characters when applicable. A 3-character code is only valid if it has no subdivisions. Always code to the level supported by documentation. Code all conditions that coexist at the time of the encounter and affect care or management. Do not code conditions that no longer exist. History codes can be used when relevant. To wrap everything up, inpatient coding allows uncertain diagnoses and requires conditions to pass the UHDDS funnel. Outpatient coding never allows uncertain diagnoses and relies heavily on symptom codes and Z codes. And the first listed diagnosis is always the chief reason for the encounter, not necessarily a confirmed condition. Thank you for listening. I'll see you in the next episode.